Hello everyone, a real pleasure to be here today. So my name is Jenny Lamb and I work at the London School of Hygiene and Tropical Medicine as a research fellow. Today in this presentation I will introduce you to the community perception tracker approach that was developed by Oxfam and which was instrumental to Oxfam and ACF and their implementing partners throughout the COVID-19 pandemic. Here, the focus of this presentation will be a secondary data analysis carried out by the London School as part of the COVID-19 Hygiene Hub's technical support. We analysed the trends in COVID-19 perceptions among crisis-affected populations in both Lebanon and Zimbabwe. Now, before I proceed, I'd like to acknowledge all the hard-working and fantastic colleagues that are listed here in Lebanon, Zimbabwe and the UK who have been instrumental to this project. Okay, now let's take a deep dive into the overview of the problem statement here and now and the rationale. So the community perception tracker approach was developed to address several long-standing challenges of outbreak response. Within the WASH sector, there's a recognition that community engagement is vital for effective programming. But too often we lack tools to help us do community engagement systematically and in such a way that it leads to improved programming. Community engagement is also a key pillar of outbreak responses because understanding community perceptions towards disease and towards response programming is likely to have an important bearing on whether people adhere to preventative behaviours. The scale and the novelty of the COVID-19 pandemic therefore created an important opportunity to improve learning around community engagement. Originally, Oxfam's Community Perception Tracker was developed and piloted during the recent Ebola outbreak in DRC to address these challenges, and its scale-up during the COVID-19 pandemic was used as a real-time learning opportunity. And this has been progressive with ACF, Oxfam and their partners proactively developing their capacity in listening and qualitative analysis by adopting the Community Perception Tracker approach. So in short, the Community Perception Tracker is unlike many other data collection tools used by the sector. It is a process which allows frontline staff to actively listen to communities and to ask probing questions about perceptions during routine aspects of their response work. It has no set agenda and is not a paper survey. Listening to perceptions is a compelling and emotive tool in understanding communities from the outset and during outbreak response. Perceptions are systematically documented on mobile devices, coded to themes, and then analysed qualitative and quantitatively so that they can be used to adapt programming. Trends and perceptions are shared through reports to field staff and other stakeholders, which are triangulated with other data collection processes. Okay, so the objectives of the secondary data analysis included the following: to compare trends across the two countries over time, to assess whether the initial coding framework developed before the pandemic used by staff to code the data was fit for purpose, to assess the validity of the trends identified by comparing CPT data to more traditional interview data based data that was collected over between 4 and 5 rounds with a cohort of 50 people in each country. Now, through a deep dive, we reviewed and cleaned the data. We examined the appropriateness of the pre-existing coding framework in comparison to the perceptions collected. Thereafter, we carried out analysis to present an understanding of how the trends and perceptions changed over time. And during this process, we suggested develop more detailed coding framework, including both themes and sub-themes, as we felt we needed such detail to mitigate losing the nuances by having 2 broad themes. For example, impacts were further broken down into impacts on livelihoods, education, mental health, the family unit, and the community. So over the course of the research, about 1,000 perceptions were collected in each of the countries. These graphs compare the major trends across Zimbabwe and Lebanon. It is clear that there are some similarities across the two countries. For example, early on, the majority of perceptions related to preventative behaviours and the origin of the disease or its existence. The brown line on both graphs represents perceptions related to vaccines, and as we would expect, this did not emerge as a common trend until January 2021. But from then on, we see it becoming the major theme in perceptions in both countries. However, these larger trends also disguise a lot of the nuance in the data and the variations between countries, which we'll discuss in the forthcoming slides. In the graph on the left, perceptions related to prevention in Zimbabwe are consistent with the recommended preventive measures and the context prevailing in country. In January 2021, the government introduced a 30-day curfew to curb rising infection numbers, which is highlighted with the left right-hand icon. Further lockdown measures were introduced locally in a number of areas as Zimbabwe entered a third wave of infections during the month of June in 2021. This is when there's a peak in fatigue and disrespect of the recommended preventative measures. And this has been a common habit report across the pandemic, given the number of waves of COVID-19 infections and the lockdowns associated with this. Whilst the Lebanon graph on the right illustrates a better picture compared with Zimbabwe in terms of communities acknowledging self-reported uptake and adherence of the COVID-19 preventative behaviours. The blue medical icon illustrates when Lebanon had more than 1,000 cases per day, and thereafter in November, 2 weeks of full lockdown were announced. Okay, in the graph on the left, you can see that the secondary impacts of COVID-19 were much more commonly reported in the CPT data coming from Lebanon than in Zimbabwe. But when we look at the content of these perceptions, we can see that in Lebanon, this was comprised predominantly of livelihood concerns, whereas in Zimbabwe, secondary impacts on mental health and education were also reported. Of course, behind each of these numbers, there's an actual perception, documented verbatim, and it is really this qualitative-rich data that is most useful to inform programming. Okay, on this slide we show a closer analysis of vaccine-related perceptions in Lebanon. When CPT staff noticed that they were starting to see a surge in vaccine-related perceptions, they made the decision to expand their WASH-related COVID-19 work to include vaccines, which involved them applying for new funds. They also adapted their communication materials and the messages that were going out through trusted community leaders to be responsive to the perceptions they were hearing. As you can see from the graph, the grey sections of the graph, a large proportion of the perceptions expressed about vaccines initially related to how the vaccines would be rolled out in Lebanon, i.e. who would be eligible, how to register on the government system, and the barriers to getting to a vaccine centre. All were things that were of particular concern for the Syrian refugees that Oxfam and their partner Haddad were working and responding to. This CPT data led the staff to actively support the refugees to register on the government system, to provide transportation to vaccine centres, and to lobby the government to run mobile vaccination clinics. These actions not only increased vaccination rates, but also seemed to result in less concerns being expressed on this topic in July and September. Now let's look at the validity of the trends. As mentioned before, we were fortunate to refer to a parallel process evaluation research project, which the London School, ACF and Oxfam carried out together in relation to CPT. This complements the secondary data analysis that I mentioned earlier in relation to Objective 3. Where possible, we were interested in comparing the CPT data to more traditional forms of learning from populations. On the top graph, you can see that the CPT data, where people expressed doubts about the existence of COVID-19 or expressed that they felt that they would not get infected. On the bottom graph, you can see data from our 5 rounds of interviews with populations. In this case, participants were explicitly asked about their perceived likelihood of getting infected. While these graphs both reflect very different types of data and are not perfectly comparable, the dotted lines seem to reflect changes in perceptions over time. If we look at some of the more unique or contextual perceptions coming from both data sources, we can see that opinions expressed by interview participants were also captured by CPT. These findings do not provide concrete proof of the validity of the trends emerging in the CPT, but they do appear to be aligned. Okay, to summarise and conclude the strategic value added of the CPT approach, we have found that the CPT approach provides the following strategic opportunities. One perception at any point of time tells a compelling story. CPT equips staff with a compassionate, active listening and communication skills. It provides a systematic way of engaging with the community, providing real-time data about their current thoughts, perspectives and behaviours. Furthermore, it allows better advocacy on behalf of crisis-affected populations. Okay, finally, we'd like to acknowledge the many members of our programme and research staff who made this learning possible. And if you're interested in learning more about the CPT, please visit the resource page on the Oxfam's website, which is listed here in this slide. Overall, many thanks for listening, and I look forward to answering any questions you might have. Many thanks and all the best. Thank you.